All righty, welcome everybody. I'm Esther O. I'm one of the faculty members of the Cochlear Center. So today we have Dr. Julie Bynum, whom I will be introducing shortly. So just housekeeping, if you're joining by Zoom, please use chat function to ask questions and your message will be sent to the seminar organizer, then relayed to the speaker. And just a reminder, the seminar is being recorded and we're providing closed captioning. So Dr. Bynum is the second of our 2021 to 2022 seminar speakers. And these are the other speakers who'll be coming up for the rest of the academic year. And save the date, Cochlear Center Research Day, Monday, April 25th, 2022, from 8:30 a.m. to 4 p.m. Okay. So I have the pleasure of introducing Dr. Julie Bynum today. So Dr. Bynum is a Margaret Terpenning Professor of Internal Medicine in the Division of Geriatric and Palliative Medicine. She's also the Vice Chair for Faculty Affairs for the Department of Internal Medicine and Research Professor in the Institute of Gerontology Geriatric Center and Associate Director for Health Policy and Research, and member of the Institute for Healthcare Policy and Innovation. Dr. Bynum received her medical and public health degree from Johns Hopkins and completed a residency and chief residency at Dartmouth and completed specialty training in geriatric medicine at Hopkins. She then joined the faculty at Dartmouth Medical School, where she received prestigious career development awards from the Robert Wood Johnson Physician Faculty Scholar Program and the National Institute on Aging Beeson Scholar Program. She's known for leading interdisciplinary research teams to study questions about the complex drivers of quality and costs for older adults and how to improve healthcare policy and performance using national administrative data, particularly for people living with dementia or nearing the end of life. In addition, she has been Atlantic Philanthropy's Health and Aging Policy Fellow, was a member of the National Academy of Medicine committees that published Vital Signs, Core Metrics for Health and Healthcare Progress, and was recently a deputy editor of the Journal of the American Geriatric Society. She's currently a member of the National Academy of Medicine Forum on Aging, Disability, and Independence, and also Consensus Committee on Building Data Infrastructure for Patient-Centered Research. Dr. Bynum leads a robust portfolio of research largely focusing health and healthcare for people living with dementia, including an NIA P30 Center for Accelerate Population Research in Alzheimer's and studies that examine the quality of care, diagnosis, and treatment of people living with dementia in the community, long-term care, and assisted living. Dr. Bynum.
Thank you, Esther. I'm delighted to be here and thank Dr. Lynn and the rest of the group for inviting me, and also all the tremendous assistance and support of the team who makes this virtual presentation possible. So thank you everyone who's here. This is my title slide. I've stolen the name of my center for the title of the talk, Accelerating Population Research and its Impact in Reducing Alzheimer's Disease Burden today. This is just a list of my support, various grants, and I also have a state contract to help with their understanding of their long-term care systems in the state of Michigan. So my goals today are threefold. Hopefully you guys can connect to at least one of the themes of what I'm going to talk about today. The first part I want to talk about, this is really going to be a 3-act talk, is helping people understand the multitude of ways that dementia influences life and well-being of the population, and how you can actually impact on that with thinking from a very population perspective, all the different levers that one can use to influence the outcomes and reduce burden of this really devastating disease from a population standpoint. And then I'm going to take a little bit of a detour to talk about using scientific language of cognitive impairment and the diagnosis of dementia to really help us connect and communicate across the scientific community. It's a particular issue if you're going to be studying cognitive impairment and dementia that I have found I have struggled with, whether that's in grant reviews or otherwise. And so I think it's something very core for us to get on the same page about. And then lastly, I'm going to talk about a couple grants that I'm involved with that are really trying to help people advance their own research in various domains of Alzheimer's disease and dementia. I welcome questions and advice on how to keep the mask on my face. we'll welcome that as well. And I think you can put questions in the chat and it will let me know because I can't see that up here. And of course, I welcome questions from anybody in the audience as I go along. So the first thing that we should talk about is all of the Alzheimer's focus. Now, those of you who are pretty early in your training program may not realize that all of the incredible funds going into Alzheimer's research didn't exist until pretty recently. And so we have to ask, why did the federal government decide to have a national Alzheimer's plan and invest tremendously into research in this field? Oh boy, we've had some formatting changes. What that little red box says, why have a national Alzheimer's plan? And you say, of course, like, don't we have a national plan for everything in healthcare? And the answer to that is no. And we have to think about what are the drivers for governments and policy for actually addressing this particular disease. So I'm going to take a step back as a geriatrician to say, what is it that's different about population aging that should make us think a little differently about how to move forward? So for the surgeons among us, like Dr. Lin, I think a lot of medicine has focused on curing diseases, reversing diseases. But when you're talking about caring for an aging population, a lot of those models sort of dissipate. And we're focusing on chronic conditions that we can't cure, multiple chronic conditions that play together, cognitive impairment and functional impairments. So the complexity of the people we care for becomes much greater. And I would argue that dementia itself is really different from other common age-related mortal diseases. So the picture to the left here is now a classic study that was published by Hurd in 2013 in New England Journal that talked about the costs of disease and really measuring those related to dementia in comparison to heart disease and cancer. That was like an age-old first sentence of every cardiac disease paper you ever saw. We spend X billion dollars on the, congestive heart failure or coronary artery disease. It wasn't really easy to do that in Alzheimer's disease until Dr. Hurd came along with this paper. And what's really interesting and different is if we think about what are the types of economic costs that we face for the disease of people living with dementia. There's obviously the human cost, right? The suffering, the difficulty, the challenge, the emotional, but there's also a financial cost. So there's those health costs, but then there's the issues of social care, supervision, safety, keeping people eating and dressing and feeding safely across their entire lifespan. And we have informal care, spousal, most people's caregivers are their spouses, or then most likely their daughters after that, and it goes through the chain of people. These are often unpaid caregivers. And what does that mean for that sandwich generation that maybe can't work as many hours? We don't have so much of the mortality costs. So we often talk about loss to the workforce for diseases like coronary artery disease, the young woman who has a heart attack at age 52, cutting short her career and her contributions to society. That's how economists have often thought about financial costs related to disease. But in this case, because it's such a late onset disease, it's the next generation who has impacts on their productivity loss. Because thankfully, for most people who get this disease, its onset is later. But of course, there are people who have early onset disease as well. And this is really different from cancer and heart disease because these are mostly issues because of the cognitive function loss, the inability to be safe and make decisions for yourself, which don't necessarily happen in heart disease and cancer. So when Hurd took into account the informal care costs related to Alzheimer's disease and dementia, the cost of dementia far outstrips these other diseases when we start to look beyond the healthcare system. The other thing that makes it really different is we don't have any effective treatments. Whereas we have cancer treatments that might slow things down, we can even prevent cancer, heart disease. We now have an epidemic of heart failure because we've been so successful at treating coronary artery disease. We don't have anything similar to that in the field of Alzheimer's and dementia studies. So if we want to achieve a goal of lessening the impact of dementia on the population, how do we do that? How would we go about doing that? And I turn back to my public health training here, probably in this building, to say, you know, if we're thinking about managing an entire population and reducing burden of a disease, well, one thing we could do is reduce the risk factors for developing the disease in the first place. That would be called primary prevention. For those of you who are public health students, we could reduce people who are at high risk. We could reduce their likelihood of progressing. So to full-blown disease. So that would be secondary prevention. The other thing we can do is once people have the disease, we can make their lives and their caregivers' lives better. And that would be called tertiary prevention. Early in my career, I was asked to speak at a pharmacoepidemiology conference, and I showed this slide. And I talked about the difference between the culture of cure and the culture of care and what that meant in funding and research that was going on. And I would say initially, much of the interest in Alzheimer's disease and the NIH funding was really around finding a cure, which was based on the premise that, well, you know, this is already a late onset disease, if we can just use some sort of therapy to delay its onset or prevent it altogether, but even just a small delay on its onset will have tremendous impact. But of course, we also have to manage the population of people who are living with disease. So there was a little bit of a dichotomy in the field. There's actually a dichotomy in the field in who studies these two different questions as well. Really, our neurologists often are on this cure side, you know, thinking about the mechanisms of disease and what drug therapeutics there might be. And people like geriatricians are often on the care side, thinking about what's the health system doing and how's it working. So I'm going to share some slides I've created over the years to really sort of break down what we can do to intervene on this disease, because I think there's almost a nihilism sometimes to say, well, we have no drug treatments, so what can we do? Well, I still think there's a lot we can do. And this is a figure I made in support of some grant, I'm sure long ago, that I can't quite remember, to really highlight this public health mindset of what we do and can do in this disease. So if you take a well population, you're going to modify risk factors. Maybe if we had better education, you know, if we had maybe if we had better hearing in childhood, we would have less dementia later, who knows? The at-risk population, we might target them. For early disease, you could treat, you could be planning to, you know, some of the late impacts of this disease are not having adequate safe environments in the future, but maybe if you do some financial planning at the beginning, we can provide some protection. You know, Lauren Nicholas led a paper recently that showed that people are having financial impact differentially in the setting of developing Alzheimer's disease. So the financial impacts actually predate the diagnosis by anywhere from 4 to 5 years. Advanced care planning. And then of course, as people get moderate disease, we treat their symptoms, we support the families. And at the end of life, we work really hard on dignity. Another way of talking about this, and I do know which grant this is from. This is from the best grant, my favorite grant I ever wrote that went unfunded in 2010. I just want to make you all aware that you get to the end of the career and you have lots of failures all the way along the way. But this is a way I was trying to convey this notion that there's many things we can do. And it's going to take a lot of different investigators and kinds of interventions to really reduce the impact of this disease. So again, the top here is just showing what I've already said, this idea of primary prevention, secondary prevention, and tertiary prevention. But then I was thinking about how you would actually intervene. And so often it's a population intervention if you're doing that first primary prevention piece. Secondary prevention is also often at the individual level. It's something about they're changing their diet, they're doing something, I don't know, more Sudoku. Let's see, I'm not exactly sure what's going to be effective there. But then in this last end of tertiary prevention, frankly, where most of my work is at is on the delivery system interventions. What are we doing or not doing in the health system that's either making lives better or worse for people living with this disease? And so on this bottom of this slide, I've just sort of thrown up some different ideas of what you might do to sort of trigger people's thinking to think more broadly about how we can intervene and maybe trigger some ideas about what you can do in the future. More recently, as I've thought about this, I've been trying to convey the notion that what I do, which is mostly health system and health policy, I feel is deeply connected to principles of epidemiology and public health. And that in my mind, at least, this is a continuum. And then I found this nice paper by Professor Hunter. It just came out. It's an opinion piece about the relationship between public health and clinical medicine. And I felt like, wow, he really summarized what I have always been trying to convey in a lot of the work that I've done and to my mentees and to my lectures, thinking about where the impact happens. So as I've thought more about it, I really wish I could articulate better this notion of a continuum from public health to delivery system to clinical medicine. I sit on a lot of committees. I'm on the America's Health Rankings and other kinds of discussions of system performance. And I often hear this discussion between, well, this is public health, and that's healthcare, and that there's some sort of divide that we're all supposed to understand that exists between these two domains. And I find that very challenging to both articulate and describe, and also as a useful construct, frankly, for what we're attempting to do. So if I'm thinking about how to extend the impact of my research in whatever domain, whether I'm an epidemiologist or doing something in the healthcare system, I want to think about that corollary that we've learned about from that bench to bedside, right? That notion, or intervention development to implementation. And what they're always saying there is, as you're designing your study, wherever you are on that continuum, we're always thinking about what's the lever that's actually going to implement or take what I learn and make it useful to the population. I'm not necessarily the person studying the payment design for how to pay for hearing aids or something like that, but I might be thinking about that's going to be important down the road once my study has been designed and moved forward. I'm not sure if this idea really resonates with people, but I'm just going to give you a couple of examples, again, of things that I've used in teaching and in lectures that I think capture this idea I've tried to communicate about the continuum. So this slide is, oh, that's when I made that too. I made this picture for the Health Affairs special edition dedicated to Alzheimer's disease. And what this slide is trying to convey is, where are the policy levers that exist for different sorts of interventions? So if you are really interested in primary prevention, that's going to sit in the public health realm, CDC. If you're really, really committed to palliative care, you're going to sit in the healthcare, and you might be funded by NIH and those kinds of organizations. But what if you're really interested in the burdens on families and the problems of caregivers and their support? Then you might look to the long-term care group. And in the policy environment, these are all separate groups. The big ones that really, I think we have yet to even begin to tackle are labor policy. What do we do about having the appropriate workforce for caring for people in long-term care? What do we do for people who are caregivers who need support and can't work full time? Some states do waivers so that caregivers can actually, who are on Medicare, Medicaid, so that the family members can be paid to be caregivers. What an interesting policy intervention. And what about justice and law enforcement? What do we do about financial exploitation and how banks are functioning? So depending on what you're interested in, the nature of this disease is so complex and it has so many tentacles. You can imagine lots of different ways policy may be able to intervene on the outcomes for this population. But if we're not aware that these are the policy levers, we might go down the wrong path of trying to take what we've learned and converting it into an actionable idea for the population. Similarly, if things are going to happen in the healthcare environment, we need to understand the healthcare environment and where people with these diseases live. And not to be too blunt, but who pays the bills? So if you think about this, if you think about the parallel to government, so in government, you can legislate, but it's actually the appropriation of funds that makes things happen. We've all heard the unfunded mandate terminology, right? Creating a mandate with no funds behind enforcement or funds to make it happen means it won't happen and the regulation won't be applied. So it's the same in the healthcare environment. And I have been surprised how many clinicians, physicians in particular, are not really aware of how people in our communities get services and how they're paid for once they're outside the clinic or the hospital. And for this population, it's critically important. We need to understand that assisted living is paid out of pocket. So if you're going to do an intervention in assisted living, you need to understand what kind of care providers are going to be there, who's going to pay for it. And then community-based services, I would love to see us intervening in adult day programs, senior housing. That's a completely different siloed system in the American healthcare system, where in other countries that's not the case. But you need to know that AAAs exist if you want to partner with a community-based organization to reach your population of interest. So it behooves us to really understand the system and the payers. This is just a slide that's in a chapter of a book I wrote to just say how many different ways the federal government funds things that impact the lives of older adults, depending on what the domain is. So I'm going to pause there. Are there any questions before I launch into anything else? Did I whet your appetite to go do a health policy fellowship? Great. Because I'm going to change directions now. Because all of that I just said means you're talking across disciplines. You have to be able to communicate and be a translator across disciplines. And that's challenging in our field. So back in the day, when Esther and I were fellows, this is what we learned as what dementia is. Dementia is an acquired syndrome of decline in memory loss and other cognitive abilities serious enough to interfere with daily life, and there are certain common causes. And the figure is what I really want you to focus on in this timeline. The way we conceptualize this, there was the early phase, the mild to moderate, and the severe, and it had about a 10-year timeline. Today, we don't think this way. We think all the way from normal, pre-symptomatic, subjective, mild cognitive impairment, early dementia, late dementia, and death. And that 10-year window sits way over at the far part of the timeline. So I say this to remind us that the language that we use is really quite different from our current conceptualization of how this disease evolves. And these disease labels and definitions really matter in research. This is just a timeline, all the diagnostic criteria that have come out, and they're often driven by technology developments. So the original diagnostic criteria were pretty soft. Didn't really matter because we truly didn't have specific treatments, but drugs were approved. And then they didn't seem that effective. So maybe we need to treat earlier. So the definition of MCI happened. Then we developed PIB. We can detect amyloid in the brain, and the definitions continue to evolve, even as recently as the last couple of years, to address both our understanding of the disease and our technology abilities to assess them. So I want people to be really cautious. This is actually a slide I use to talk to my health economist friends, because they tend to be less nuanced in their use of the terminology. So I wanted them to be really cautious about how they're using their words. Cognitive impairment does not equal dementia. Dementia is a general term. Alzheimer's is a specific cause. And be really clear about this little schematic to the right just says in 1984, we were talking about a dementia syndrome, which is the diagnosis or the definition I gave you earlier. And that still holds today. I think people still use that as the definition of the clinical syndrome of dementia. In 2011, we split out NCI, and we also split out AD, Alzheimer's disease, as a cause from other diseases, and made that a much more distinct change. Then in 2018, we said, well, wait a minute. There are clinical syndromes or people having symptoms, but there's these biologic signs of the disease that predate by decades. What do we call those? So the language now, and I'm not going to get into this debate, but people use Alzheimer's disease as opposed to Alzheimer's dementia. And so these use of language is really getting complex and nuanced. I'm going to pause there and see, is there any comments, or is this something that resonates with what you are all thinking and hearing? This is actually technically, all the use of biomarkers is not my expertise, but what I've experienced, and you will too if you write grants in this space, your stakeholders and your reviewers are coming to this with their own lexicon. We have not settled it down yet, so that my experience, I write a lot of grants using Medicare claims data. And if there is a biology-based neurologist on the study section, they will say, you can't say anything with Medicare claims. You don't know what diagnosis they really have. You don't know if that's Alzheimer's or Lewy bodies. And I have to say, correct, I don't. But for the question I'm asking, I'm interested in the clinical syndrome of somebody who's going to struggle in the healthcare system. So the type of disease doesn't actually matter for my question, but that neurologist is still scoring my grant. So I need to be clear about what I'm trying to communicate and what words I'm using, and be sensitive to the fact that our field, in Alzheimer's disease, encompasses epidemiologists, neurologists, pathologists, geriatricians, I don't know, I can't think of everyday economists. And we need to be clear about what we mean, because has anybody seen a headline about Alzheimer's disease at all lately? Right? The media picks it up and they will use it. And often we can make false hope or get people misdirected and really lose the focus on what really matters if we're not careful. So now getting more into things I think about a lot. When you're designing your studies or thinking about it, thinking about what you want to study, the data used determines the disease construct studied. You could flip it the other way. Depending on what you want to study, which disease construct will determine what data you have to collect. So if you weren't interested in the biologic underpinnings of Alzheimer's disease, then you need to have blood, CSF, imaging. If you're interested in the clinical syndrome of people who have dementia and how they're experiencing the health system, it may be okay to use billing data, which is marking down what the physicians and the nurses and the therapists think is dementia, because that's the care they're receiving is reflective of that. Now there's all these new non-traditional data sources, using handwriting and life space assessments, trying to incorporate that into my framework of what does it mean to be at risk for dementia. It becomes even more complex. And that's I'm really going to the last part of my talk, to talk about resources and where we go from here. This is a screenshot of our center grant. It's the Center to Accelerate Population Research in Alzheimer's Disease. And this is a grant that I wrote when I arrived at University of Michigan. I have all my crew is Ken Langa, who is, many of you know, he's a physician and very involved in HRS and did the ADAM study. Edward Norton, who's a health economist. Deb Levine, who's another physician who studies vascular dementia and racial disparities. And then Donovan Moust, who's a geriatric psychiatrist, and Matt Davis, who is a data scientist. And not all of them study Alzheimer's disease, but we really noticed is a lot with all the onslaught of funding and a lot of secondary data out there, there's a lot of new people entering the field. And with that flood, there's just not enough people with enough experience to be senior mentors for all of these people. Because it's not just junior people who need mentors. There's lots of people who are converting whatever work they did before into the field of Alzheimer's disease. So people who study heart failure are now saying, well, what are the cognitive implications of heart failure? And how do we think about that? So the way we designed this study, we really focus on a particular area of science and a method using secondary data. But we wanted to provide people with a real on-ramp for coming into this research. I jokingly say everybody wants Ken Langa as their K Award mentor. He's not available to everyone. So with his permission, I'm giving Ken Langa's wisdom away in an asynchronous way. That's how we have designed the CAPRA grant. So if anybody knows these NIH funded, this is NIA funded center grants, and actually you have one here. Jen Wolf has one that has a slightly different emphasis than what ours is. You have classic things. You fund pilot studies. You have an administrative core for organizing things. But the thing that I had really a great deal of fun with was the research resources core. And we've just had a blast developing what's up in there. And again, it's not just the mentorship that we're giving away. We're trying to give tools and bring everybody's level of knowledge up to try to both improve the quality of research that happens by newbies to the field and make it easier. You know, everybody should not have to be at Johns Hopkins or University of Michigan. There's a lot of great contributions that can be made all across the country, wherever you are, and we want to make that available to people. So I'll share a couple of the fun things. This is probably the most fun thing we're doing. We have a podcast. It's called the Minding Memory Podcast. And that's Matt Davis on the right and Donovan Moust on the left. And this is actually just launched, so you can follow and whatever you do with podcasts. I'm far too old for this, I've decided. But this podcast is targeting like cool things that are happening, interesting people, interviewing them, seeing, you know, again, this is like those mentorship moments that you get from talking to somebody that you don't get from just reading a book. So for example, Ken Lenga has written about what is the true value of a dementia diagnosis and early diagnosis. So Ken talks to Matt and Donovan about that. With the approval of Adelhelm, we actually got Nick Bagley and Jason Karlowish. These are not released yet. These are coming out like next week or the week after. But it allows us to really have more conversational insights from real leaders in the field. One of the really fun ones is Matt, who is not a clinician, administered the telephone interview survey during a podcast to Donovan, the geriatric psychiatrist. I hear that he only performed moderately well, but it's sort of to give you that experience of something that you might read about. Oh, they use the tics, but to actually hear what it looks like, sounds like. So the other thing we're doing is a seminar series that's completely asynchronously available. I don't know about you, I get invited to about 50 online seminars a day. They usually are available live and then you can follow them after. We are not doing the live part, at least not at this moment in time. We're presenting them, but this is again, some basic, we call them mini semis, as in mini seminars, rather than a full hour. These are about 20 minutes, 30 minutes. The plan is to keep developing these so we can have little pieces of information with slides. So you can learn about what are the cognitive measures available in the National Health and Nutrition Examination Survey. There are some, who knew, right? And you can do some population studies with that. Again, you know, cognitive assessment in the HRS, what does it look like? How does it work? Again, it's a little bit more rich than reading it in a book to actually hear Ken Lenga or Donovan Moust, who uses NHATs all the time, talk about that. In companion to that is our data products. So it's fine for me to tell you that NHANES has cognitive measures, but what we're also doing is abstracting the data, creating SAS code or script to make it easier for people to just get into where they need to be. So there's different ways depending on the data source that we're doing this, making programming macros, sorry for the spelling error, finder files so that if you just want to identify the people in the sample who already meet the criteria, you can find them. We plan to do other kind of macros, like what are the NDCs for dementia drugs that everybody has to go and look up themselves, like just reducing some of those barriers. The other thing it does, from my perspective, is some QA or QC, I guess. With each of us, if we all sat down and programmed Dayhe's new frailty measure, we all programmed it into SAS, it might be a little different every time it ran. So if we can get some standardized code that's been vetted by some excellent programmers, the idea is that maybe we can make it a little bit more standardization as well. I'm just thinking if there's anything else to say. I show you the list of what we're creating, which files, you know, and I have to say these are all different. Like if you know the behavioral risk factor surveillance system for dementia researchers. So there's a caregiver segment in there. It's been available since, oh gosh, it's probably been 7 years since they started doing those questions, but it's been spreading through the states. And so now, like most states, have some caregiver information from this survey. Really interesting that you can actually get that from a state level data set. So this is the fun CAPRA grant that we've been doing. And I know Dr. Lynn was interested in what we sort of built into there. And these are the parts that I think are most unique to our design, because a lot of these center grants are actually similarly designed across the country. Any questions or thoughts about that? Because I'm going to switch gears to my last different pit. I think we're okay. Plus I needed to take a breath. All right. So now for something a bit different. There was a call for grants, and that's what that top little funding opportunity title. NIA ADRD Healthcare Systems Research Collaboratory. That went out. The idea is that we really need to provide care to people living with dementia and their care partners. And that we have lots of non-pharmacologic interventions for a variety of things, but they are really not adopted. And one of the ways, one of the challenges is the traditional randomized trials in which these interventions are developed. All these shortcomings, they're great for efficacy and knowing whether they work, but they're often in limited settings. They're not in diverse populations. They're also really expensive and not real world applicable when you try to go and use that information in the community. So that's where the idea of pragmatic clinical trials, and I just realized on the slide, it doesn't say pragmatic clinical trials in there, but in pragmatic clinical trials, a clinical trials designed to be a data collection system and outcome measurement that can be widely implemented. So this is where you might see cluster randomization of emergency departments or nursing homes. And then the embedded part is embedded in healthcare systems. So this endeavor, and that led to our NIA Impact Collaboratory, which is now in its 3rd year, I believe, and is an enormous effort. I think there's 60 investigators on the grant itself, dispersed all across the country. And what's really fascinating, the goal is to fund and support pilot investigators and to develop resources so people can do pragmatic trials in this space of non-pharmacologic interventions that support people living with or at risk for dementia and their care partners. But it's not actually conducting the research itself. So like CAPRA, it's not saying, okay, we're going to study this intervention or that. It is entirely based on lifting the field up to be able to be ready and move forward. I'm just looking, are people familiar with pragmatic clinical trials? Is this a term that we know? Yeah, good. So pragmatic clinical trials, these are just some of the principles. I mean, I think we kind of want this in all clinical trials, but it's really a serious investment in the pragmatic clinical trials that you're designing with stakeholder input, which includes the healthcare system where you think you're going to implement. You don't design something that's going to be implemented in assisted living without going to assisted living and figuring out what their workflow is. We're using data that is not so resource intensive. And this is where my role is. I'm actually the director of the technical data core. So we are doing things like validating algorithms using claims-based diagnoses, but also how do you find people? Are the algorithms in electronic health records where we can use natural language processing and other kinds of tools? How can they translate and how do we get people access to them? Those kinds of things so that data collection can be less expensive, but also you end up, when you use this kind of data, when people don't participate in your trial, you still see the people who don't participate because their data is still there. So all those issues of generalizability and some of the issues of health equity, we can actually still see it in these pragmatic trials because we have data on both the participants, true, full, same data on both the participants and non-participants, which gets to this diverse and representative study populations. I think we all know that particularly in the space of Alzheimer's disease, we have a lot of studies that are registry-based or people who volunteer for clinical trials. We have a major, major problem in this field in getting representation of underrepresented minorities in studies. It is just tremendously difficult for recruitment. And one of the opportunities with a pragmatic clinical trial is if you're actually doing something that can be safely randomized at a health system level, you're not trying to recruit individuals, right? So you're doing an intervention that is deemed, does not require consent at the individual level. You can actually engage a much more diverse and broad community. And also this idea that you're going to collect outcomes that are really broadly applicable to all decision makers in the health system. We have, I think, 10 cores in this grant, and there's a health system core where we have participation of a variety of health systems to both be a place for, say, I keep picking on Esther because she's sitting in front of me. Esther wants to do a clinical trial, a pragmatic clinical trial, but she knows she can do it in her own hospital, but she needs 3 other sites. How's she going to find them? So a lot of times the way it works in our academic world is, hey, I know you, I'm going to knock on your door, and it's sort of buddy to buddy, or somebody I've trained with. But this is actually an opportunity to have an audience with the groups that's already convened, and you could vet your idea to health systems and try to recruit groups to participate. This is a really detailed slide on the top level to say that what counts as a pragmatic trial versus an efficacy trial, and what is right for a pilot study versus a full-scale study versus all these things is fairly complex, and NIH has some good strong rules about that. And so something that if you're interested in this, the U54 group is very well wired for helping people think this through. But what you see along the bottom is all the different things that we're doing as part of this knowledge generation. So like the work I'm doing in the TDC, we're developing tests of an algorithm that's called eRadar, and we're actually going to run it in 2 or 3 different health systems, because usually these algorithms, they get tested in one health system and never tested in another one again. So we're actually testing whether it performs the same way. Pilot funding, there's also a training institute, and then we have a true persons living with dementia stakeholder group involved. And this is just a slide of the variety of things that are out there. So in addition to the pilot studies, I want to call out 3 things. The training workshop, I think it's a virtual workshop. I think this year's January one, the signing up has already passed. There's also a career development award, which is like a mini K. And then there's a healthcare system scholars award where somebody can go and embed themselves with the health system to learn what the health system really values and how you would actually do your research in that context. So that was my last slide. This is just a summary slide. And I think I'm hopeful that 3 points have come through. I had 3 goals, so here's the 3 points. I'm hoping they match up. I'm hoping now you're more cognizant of the multiple ways that you could possibly intervene, and maybe can be a little bit more creative and thoughtful about, oh, that's actually an opportunity that I haven't thought about. The scientific language piece, it's highly nuanced, and I learned IMO from my son, in my opinion. Yeah, you texters know this, in my opinion, is not very well agreed upon. So you need to be intentional, clear, and aware of stakeholder reviews. And really don't try to do this alone. Like, there are resources, there are people out there, there are investments, take advantage of them. I think it's hard when, particularly in a big institution, you guys have it all, right? I have it all in my own institution, but all institutions have their own expertise, and sort of having your head up and knowing what else is available can maybe, make that glide path a little smoother. So I'm going to stop there and hope that I'm not over time. Thank you.